Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
Hello, everyone. Welcome to another episode of the Life of Flow podcast. And today we had an amazing conversation with somebody that we didn't really know that well, but it was an amazing surprise. Pedro Martinez-Clark. He's an interventional cardiologist, originally from Colombia, founder of Amavita Heart and Vascular Health. Amazing career, trained at Harvard, at Beth Israel Deaconess Medical Center, then went to the University of Miami, and then started creating his own little empire. And he's a wealth of information around the business of vascular disease and the treatment of vascular disease in an outpatient setting. And we're going to have this guy again because there's so much more we can learn from him.
He's one of us, man, period. You know, es uno de los nuestros. For some reason, I don't know why, it's unclear to me, but he has escaped the Handle-lot bandwidth, but now he is into it. So I hope that he can join us in Costa Rica too. I hope you guys enjoy this. Conversation was so good.
Vamos.
The following podcast is not relating to my teachings and work at Del Cedar Medical Center and is for entertainment purposes only.
All right, man. I honestly, this is really cool to have you here. We've been trying to set this one up with Pedro for a while, but
It works when it works.
Exactly.
Yeah.
And when it works, it's magic. And that's how, we've become the number one podcast in America. Displaced Rogan.
Huh?
We displaced Rogan altogether.
You're really manifesting there.
Oh, man. But Pedro, maybe a high level for our audience that is new to you. Where did you come from? And maybe give me a little summary of your career path to get to the point where you're at now.
Yeah, no, absolutely. I'm originally from Colombia, South America, and I kind of grew up in both places, United States and Colombia. And relevant to today's conversation, I did my cardiovascular training at the Beth Israel Deaconess Medical Center in Boston, where I did interventional cardiology and a fellowship in endovascular. And I was always passionate about disparities of care when I was in Boston. So I wanted to look at Hispanics as it relates to Hispanics and Blacks as it relates to acute MI interventions of acute heart attacks interventions, and who gets more thrombolytics and who doesn't, and et cetera, all health disparities in cardiovascular care. And I noticed huge disparities in cardiovascular care in the PAD space, the peripheral arterial disease space. And then I became very interested in that because I wanted to come to Miami, and I was going to do academic medicine at University of Miami, which I did for a while. And I needed or wanted a topic in an area where I could bring to and study for a while and kind of build my academic career around that.
And I'm sorry, UM is University
of Miami. I'm sorry.
Okay.
University of Miami.
So you joined staff. You joined on UM as staff after your training.
Exactly. So I finished my training in 2007, came as faculty at University of Miami, and I was doing pure academic medicine, research, device development, teaching, and lots of procedures in the cath lab, and working very closely with our vascular surgeons, really cool group of guys at University of Miami, and we had a really nice relationship, and still do. And then that cycle, you kind of ride that for about 8 years, and about 8 years ago, I left the university because I wanted to have my own practice, do my own thing, for a lot of personal reasons also.
Do you mind expanding if you feel comfortable?
Yeah, of course, two reasons. One, when I came to the university, I had a mentor whose name is William O'Neill, Dr. O'Neill, very famous guy. We treat acute MIs with primary intervention partly because of him. One of the first guys, probably the first guy in the country who did thrombolytics in an acute coronary syndrome and acute MI. I mean, huge guy, and a great person and a great mentor. And I don't know if it's happened to you, but I'm sure it probably has. But for me, he was kind of my inspiration, and we were doing amazing things. in Latin America. We were doing amazing things locally. It was just an incredible thing. And like anything, things kind of have a cycle. And he was the dean of clinical affairs at the university, and his cycle run over, so ended, and he went back to Detroit, where he was originally from. And I mean, he offered me to go back or to go to Detroit with him, but Colombian guy, after spending so much time in Boston, etc., already acclimated in Miami, and I was like, Bill, I love you so much, etc., but I'll stay in Miami. And I have my family here, a young kid, my mother, my brothers. It was the first time in many, many years where all my family were together in the same place. So it was really, really nice to be here. So those are the reasons why when he left, my inspiration to be at University of Miami was no longer there. So I was working, I was doing 700 cases a year and, huge volume. And I was like, look, if I don't have that inspiration at UM anymore, I mean, what am I doing here? My DNA is not, I love academics, but that's not my thing. I'm more of an entrepreneurial guy to start projects, programs, things like that. So I started my own practice because I wanted to practice medicine in the way that I wanted, and etc. And have my own, practice philosophy, and that's how Amavita got started, which is the name of the practice. And Amavita basically means love life. And the whole idea was to deliver cardiovascular care, but with a positive attitude, right? To be a positive space. Buena vibra, like we say in Latin America, right? So our offices are all full spectrum. We treat very affluent patients, very poor patients, doesn't matter. Very nice experience to everybody. The offices are nice. They smell nice. They have music. I want positive energy and positive experience when patients, consumers interact with us. So that was the philosophy, and it's been pretty successful. We have 3 very busy offices, and then I expanded to an OBL a few years ago. And then after the OBL, transitioned to surgical centers, which is a huge topic in cardiovascular medicine now.
Was that from the conception? Were you thinking of giving these clinics, I don't want to degrade it because I don't think it's a bad thing, but almost like a med spa feel? Be there are an organoleptic senses, right? You walk in, there's a smell. You walk in, there's a sound. You walk in, there's a look.
It's a human experience
that creates an experience. Exactly.
Yeah.
So you're not there just to see the doctor.
Yeah, you're not a cattle.
You're there.
Yeah.
Was that how the whole, like when you were sitting on the napkin, when you were about to say, I'm going to quit screw this place, because I'm sure there was days like that. My mentor's gone. I dislike the new chair. They try to, drive doctors like cattle, and they make us work more than we should. Anyway, and I'm going to quit. And you started writing on a napkin, what do I want to do? How do I want it to look? Was that part of the recipe?
Yes, exactly. So I wanted to be almost like imagine the JetBlue of airlines, basically. So I wanted it to be a nice experience. That I wanted it to be positive. I wanted it to be nice. It doesn't have to be, and there are a lot of, we can get into a lot of economics and things that I've learned over the years, but there is a way that you can create a nice experience, a nice environment. If you look at the patient experience, 80% is non-physician. So we only 20% of the interaction. So that's why the call center has to be very nice. The front desk, the checkout, everything, every touch point has to be really, really good, because you're only 20% of the experience.
How do you build that? And we'll get more into where healthcare is going and the diversification of sites of service. But I'm here at this point where in the building of hope, and by the way, thank you offline, you complimented our look, and that's something that we pride ourselves in. But building the culture, and I don't want to be blunt, but you're dealing with hourly personnel that may not necessarily be highly educated. I mean, they're answering phones because that's what they can do, but you expect them to have this really important point of interaction, to almost care that things go well. But my experience has been that it's very difficult to get to that, and then it's almost like you have to invest a lot of your own time, non-physician, non-medical, non-clinical, to almost train like customer service, like you're going to be picking up a phone if somebody calls customer service at Amazon, that sort of thing. But how did you create that, and which tools, or how many people did you use, or are you do you know somebody that's great at it? Like,
That's a great question, and I think there are a couple of points there. You're lucky that you're one of those physicians that recognize the importance of customer service, etc. Because most of us, we're trained to be good doctors, etc. And there's so much about business that needs to go into a practice to be successful, besides the actual clinical medical decision making, right? Um, so that's important, and you're one of the lucky guys that recognizes that. Most of us, most of physicians don't. So I'm one of those guys that I've always been interested in business, in ventures, and starting companies. Most of them have failed, so therefore I've learned a lot from my mistakes.
that just says that you're a good businessman. I'm not joking.
No, I know.
No.
You try,
The
you try.
average entrepreneur fails, I want to say, I look at this 100 times before one hits.
It's a lot.
And you have to be okay with that.
Yeah.
Overnight success that took 10 years in the making, right? So exactly. But one time I was so frustrated because I was seeing patients, and patients they were like, "Hey, doc, we really like you. We want to come see you, whatever, but it's really hard to interact with your practice." Complaints. So, and then you're dealing with cases and this and that, and you hear all these complaints. And one day I was like, you know what? I'm fed up. And luckily, I'm from Colombia, South America, so I was very involved in some projects in Colombia at the time, and I had a contact in a contact center, and I called this person, and I'm like, "Hey, I'm having this problem," and I don't know if you've ever called customer service in Colombia, and I mean it's just amazing, the service. They just want to buy whatever they're selling.
Yes, so
Literally, I'm not kidding.
No,
They have
it's
this
dangerous. I'm
really
telling you.
yeah.
One of the
Yeah.
most expensive trips I went to, I want to say, era la Asociación de Radiología, la ACR. They did
Sí, sí,
something
sí, sí, sí.
in Medellin.
Yeah.
And I went to a
Yes,
mall.
yes, exactly,
And
exactly. You want to buy everything.
And I mean,
Yeah.
papacito, venga, pues para acá, ta. I'm like going home with like thousands of shit that I didn't need, because every store I
Yeah.
walked in, I was sold something.
Yeah.
I totally gullible.
A frustrated 80-year-old patient will call, would be really, really mad about whatever. And a paisa girl like the one that you're describing will be like, señor, ¿por qué está tan bravo? ¿Por qué está molesto? ¿Cómo lo hago reír? It will completely change the dynamic. So I experimented with that, and that was a turning point in our practice.
But are these people
They are in
off-site?
Colombia.
Are you using a call center off-site?
Exactly. So we experimented a little bit with them, and it was a very, very successful thing. And check this out. When we did the first pilot, we noticed that we were missing 70% of the calls. 70.
Whoa.
So just by having good answer, and response time and stuff like that, and phone interaction, we capture that 70%, and we went to, right now we have a 98% answer rate.
Wow.
98%.
So
So that's
important.
huge. Yeah. So we don't miss a single phone call, etc. So the project started to grow, and then I basically told them, look, I'm going to help you develop a specific call center, data management, all of that for healthcare in the United States, so you can sell to other practices. I'm going to help you develop it. Let's do it together. So that's what we did. And right now we have all the back office support in Colombia, authorizations, verification. We don't have anybody in Miami that is not direct patient care or a manager or etc. So if you don't have direct patient care, that position is in Colombia. And that helped us with two things. One, customer satisfaction increased exponentially. Revenue increased because we were missing so many phone calls. So just by capturing the phone calls that were coming in, our revenue increased. Number three, employee retention. You employ a person in Colombia, give them a nice job that is still lower than what you pay in the US. That patient is so grateful, is so loyal. They're committed to your mission, to the practice. We haven't lost a single employee in Colombia since we started.
How many people do you have?
Now we have nine.
So the whole thing, answering service, RCM.
Insurance authorizations, insurance verification, all of that.
What's the name of the company?
So it's called Contacta.
So do they work just for you, or do you at this point provide service for other practices?
Exactly. So now they have, I believe they have about 12 practices already, fully bilingual.
I want to hear like one of the like paisas from Colombia talking to some guy from the Midwest. Like, "Ay, papa, listen to me, papacito."
Let's call him. Can we call the answering service right now?
But let's say that you're practicing Texas, for example. I'm sure you have 30% Hispanic, or whatever the number might be. So even if you start by just routing all the 30, anything that is Spanish goes there, you free up so much stuff here for your, and you save. The operational cost went down significantly. I think we saved in operation. In those positions, we saved probably 30%, if not a little bit more.
Yeah, I mean, I'm already thinking, as you're saying that, I'm thinking if I had that service, I could probably let go 4 people. Which I mean, I know it's kind of screwed up for them, but I'm just saying those 4 people.
I hope they're not listening to this podcast.
Nobody listens to nobody. My wife doesn't listen to this. She's like, I listen to you talk all day long. I don't care to listen to you on the radio. But anyway, those salaries, let's say, grab that salary, probably surmount to say $150,000, $170,000, and then half of that, if not less, is what you would pay for a service like that. So you're creating margin. Yeah. You're just creating margin.
Yeah. And not only that, but you hire and obviously there are regions in the country that have let's say Minnesota, people are very nice, employee retention is higher, just people are generally nice. In places like Miami-Dade, it's really hard to retain $16 an hour jobs, $20 an hour jobs. Those is really hard. It's the turnover, the constant training and turnover and stuff like that. So just if a $20 position here, you pay, even if you pay $15, you saving $5, but you are generating so much loyalty, and you're avoiding that turnover, that constant training and retraining, because every time a new position comes, a manager has to sit with that person and spend a week or two teaching the whole process. And, so you end up saving a lot more than just the difference in hourly rate.
How do you, with your inpatient staff, how do you create the culture that you want to create? How do you create the human culture with somebody in person? Yeah.
You clearly have to define what your values are and what kind of experience you want your patients to have in the practice and what kind of energy you want. And then you really have to work with your HR person or whatever mechanism you have to recruit, and really look for those skills and the personality skills that you need to be able, because the rest you can train the person, but you're looking for the type of personality traits that are important for your practice. And so it becomes a recruitment philosophy.
How much of your time do you spend in non-clinical matters?
That's a good question, because you can say, okay, I probably do a lot of non-clinical stuff. It's long days, right? We're not talking about 8-hour days. We're talking about, I'm if I'm awake, I'm either working or working out, right? So maybe having dinner with a friend, but for the most part, we are accustomed to work pretty hard. So you kind of mix it in things and stuff like that. And I think it's very important to have a very good team around you. I've been blessed to have, be able to put a very good team together. Our medical assistants are great. They're so good with patients. The techs are just a really good team. The team cohesiveness is so important. The nurse practitioner, the mid-level providers are so important. Also invest a lot on the mid-level providers, train them, educate them. We have 2 hours a week of education for our mid-level providers
That you give them, or you give them time to do it themselves, or how?
that I give them. So, and one of the things that I do, that I think is added a lot of value to my practice at a personal level, is I'm very grateful for the mentors that I had when I was in training, right? So I wouldn't be here if it wasn't for 2 or 3 mentors that were key in the very important moments of my career. So I want to give back, and I want to mentor people. So since I graduated from fellowship, I've always had that philosophy that I want to mentor somebody. So I usually take or bring one of the top 10 Colombian doctors that graduate every year and train them for a year, and I cover all the expenses. And that person, and I'm happy that I do that. I love doing that, and as long as I can do it, and in fact, I wish I could expand that, and I want to, and at some point I will. So every year there is a really talented young kid or woman that comes, spends a year with us. I train that individual. He or she teaches a lot the mid-level providers. He or she becomes a so much better candidate for residency. And if I give you the track record of, I think it's like we're at 12 already, they're all super successful today. They all have match in amazing places. They all have great fellowships. They're all super successful.
These are right out of medical school.
Right out of medical school, exactly. So, in Latin America, similar to Costa Rica, Servicio Social, etc. So right after they do that, and it's become, I get applications already from people, and one tells the other, hey, I want to get in there, I want, whatever. So it has become a thing in Colombia. It's been like 12 years now, and all of them have been extremely, and so grateful for that.
Yeah, one of the things that I've done that's worked really well. There's a couple of things, but hiring physicians that want to be in the U.S. or that have migrated to the U.S. and they're in the process of getting their paperwork, but you can't hire them as a physician because they're not certified. They don't have a license, but they need to work and they want to work in healthcare. And so what I do is I give them a premium over, let's say, what a medical assistant would make, because there's a recognition of what they bring, but I put them into medical assistant roles. And so, man,
They go
so your notes, the data that comes in, I just got another guy here that's being the research coordinator, and he's doing amazing. And he's the guy from Mexico, and they're different because with them there's a NAFTA agreement based that allows us to get them some visas.
Okay.
So I can sponsor for up to a year a visa for laboratory assistance and for clinical research. And so they can essentially apply. And so there's always, literally every week I get people saying, hey, Dr. Montero, do you have anything? Because I want to do my boards.
Yeah.
I want to be. And so I can take one of these visas. They're called TN, temporary visas. And I can come for a year and work for you, but they're doctors, and so it's a really good option. I started doing that back at Baylor, and I've continued to do it now at Hope, and it's a phenomenal way to up level. And then what happens is all the other ones that are not necessarily doctors, they up level.
Yeah.
Because now they see the other guys working and doing all this stuff, and they're like, okay, well, I'm gonna try my best to relate.
Yeah, no, absolutely. So similar. I haven't explored the Mexico route, but I am familiar with it because when I was starting to do this, I looked into that. But the Colombia thing kind of grew, significantly. But that's exactly the same.
Yeah.
So let's transition now into the kind of more tactical move from OBL to ASC. What kind of knowledge pearls can you give us?
Yeah. How long have you had an OBL?
About 4 years.
Okay, so 4 years. Have you felt the transition of the reimbursement significantly? You feel the burn?
Yes, yeah, absolutely. Yeah, our reimbursement for OBL procedures has dropped significantly.
I want to say 40%. Not a lot of business can take a 40% hit. It's a really it's a big problem. So anyway, just to set the stage. Okay, 4 years, you've seen it go down, and a lot of us feel that the only way out is going to an ASC. What's your thought?
Exactly. So I agree. And at least from an interventional cardiology perspective, obviously, in vascular surgery, you have other procedures that you do or you can do, etc., that may have better reimbursement. You kind of have to look at each code and every procedure and which one is better in OBL versus ASC. And the ASC, obviously, of course, you can run as an OBL some days, and ASC other days, etc. But from an interventional cardiology perspective, there's no doubt that going to an ASC was the right move for the simple reason that coronary procedures and some basic electrophysiology procedures got approved to be done in an ASC and not in an OBL. So if I did 250 peripheral cases a year, that's, I've maxed there. The only way to expand is by doing coronary procedures in the outpatient setting. So that shifted the work from the hospital to the surgical center, and that's going to be the trend, at least from an interventional cardiology perspective. And that looks very good. That looks very solid. The reimbursement is going up. It's for example, physician reimbursement for 2025 again is coming down by 2.6% or 2.4%, I forgot. But ASC reimbursement is going up. So I think at least for the next few years, ASC is where we're going to see favorable reimbursement for what we do.
Are you still doing inpatient? Anything at the hospital or no? So when somebody or any of your patients needs a hospital, you have somebody you send them to?
Exactly. So I've been around in Miami-Dade for long enough, and I have very good relationships and get along with everybody, etc. In fact, I refer patients to, I never sacrifice patient care, meaning that if you need something tomorrow and I can't do it, hey, I call a friend, a colleague, whatever, and I find you somebody that can do it. Exactly. So I have referred patients to muscle interventional guys, vascular guys, whatever. So I have good relationships, and I know people, or we know people in every hospital, and we tell patients from the beginning, our practice philosophy is outpatient. We don't go to the hospital. We have, connections, friends, networks, etc. But set the expectation from the beginning. We don't take, for example, calls after 5 p.m. I can count with my hand the number of calls that we get after 5 p.m.
So Pedro, let me push your buttons here on that particular topic, because I feel torn. I feel the responsibility to be the shepherd of the patient in their journey, and that when they need more acute care, I almost feel obligated that I have to be vertically integrated, and that I have to have privileges so that I am able to provide that level of care to the patient. And there's almost like an expectation that the patient wants me to be the one doing that. On the other hand, when you're a solo practitioner in the hospital without a good network of support, it becomes tricky to take care of very complex patients. And last but not least, it also, when you look at the value of your time per minute in a profession in which, unfortunately, we don't sell businesses, so we generate by being present and creating units of work. And when I think of the amount of money that I can generate while being in a procedure that takes 4 to 6 hours because of its complexity, and wasting my time away because anesthesia is fiddling around with an A-line and all these things that happen out of your control, I realize the worst business decision I can ever make is provide that. But then there's this moral part of me that feels obligated to provide that. And so walk me through how long did it take you to leave the hospital? Was there a time where you were hybrid?
Yes, it took me years, and I went through exactly the same struggles, and up until recently, I did percutaneous mitral repairs, transcatheter aortic valve replacements, etc. I did all the complex stuff. But there are 2 points to that. One, when you decide to have your own business, you're committed to your patient, of course, because we're physicians, but you have to look at the health of the business. You're committed to the employees, the people that depend on you. And I remember one time, one of the, after COVID, we wanted to do a nice holiday party because it was after COVID, et cetera. It's the first time, and we basically said, you know what, let's invest or let's spend money in a really nice party because the morale has to be up, and we really have to. So we did something super super nice. We rented a small hotel in Key West. We took everybody, bring your families. Everything was great. And when I had to give a few words, there were 50, probably 60 people there that depended on what we do. So our obligation really is to the patient, of course, but also to the business. And these people believe on you. The families depend on you, and that the practice generates enough revenue that can continue to be sustainable and to grow and provide for all those families that depend on your business, that work in your business. So that's number one. Number two, because you don't do a specific procedure doesn't mean that you're not intervening in the care of the patient, right? So you don't have to be the guy who does the TAVR to make sure that that patient gets the right care. You call your colleague that you believe is the best one, that you will trust, and you make sure that your patient gets the right care. That is huge. You don't have to be. The only way that you can grow is if you delegate, right? You have to detach yourself from those things. Otherwise, you're never going to grow.
I'm going to sound like an ass, but the problem I have is I don't know that I trust anybody better than I trust myself. I mean, if I had you close,
You have Jorge. Jorge just started. But
yeah, I
Jorge's
mean,
very good.
he's my knight
You have
in
Zach.
shining armor.
Yeah.
Because I think there's a couple of guys that I
Yeah.
trust really well that I would be comfortable sending to them.
Yeah.
But it's still not enough of a network there. And the hospitals, I don't know. There's just a lot of things
Yeah.
that preclude you from letting go. But I think that's just something I'm going to have to do. Like to Pedro's position is at some point, you just have to, if you want to be as successful in an outpatient model and you want to grow and you want to have these clinics and you want to create this.
Something has to give. Something has to give. Because I found myself in, and I'm sure you feel this, but there are some days that are huge financial pressures that you have. You have to talk to the banker, to the attorneys. You have this problem, 20 million problems, and it's not fair to the patient to be thinking about all these things, and you're like getting all this frustration in because of all the inefficiencies of the hospital.
And doing a highly complicated procedure while having all those things
Exactly.
in your
So
mind. Yeah.
before the cath lab was kind of my zen space. It was like, oh my god, it's so cool to do procedures, and I feel great. This is like I'm but the hospitals become every day more inefficient and less friendly to physicians,
I hate the
Yeah.
and
hospital.
just make it so unpleasant to be
I
there,
hate hospitals.
and so ineffective and inefficient, and you lose money. So what is the value proposition? So you basically go in there to have fun, and they're not letting you have fun, because what you enjoy is to do procedures, but then they don't let you do that anymore the way you want to do it. So, something has to give.
Listen, I married a nurse, so I don't have anything against nurses. But the rise of the nursing leadership within the hospitals to have control over scheduling and procedures and timing and management of spaces, that run the boards, that run it is the most absurd thing how we've allowed to just be now in a backseat where we're victims of this whole thing that has nothing to do with us. But guess what? We're the motor of the revenue.
Yeah.
If we weren't there, nothing would ever happen.
Yeah.
But we get no control.
Yeah, it's basically like the airlines, right? Yeah, you can fly a plane without a pilot, but the pilot has no saying on the airline business.
Correct.
Yeah.
And then if you look the wrong way,
Oh, you get written up.
then you're
Yeah.
immediately
Yeah.
up the chain,
Yeah,
and then
yeah,
you're
yeah.
then you have to do these stupid
Yeah.
sensitivity trainings and so on and so forth. It just, and then you know what? When push comes to shove, everybody in the hospital turns around and they're like, "Fuck this guy."
Well, it's the diffusion of responsibility. Nassim Taleb has this book called Skin in the Game, and we have the most skin in the game. I don't care what
absolutely.
anyone says.
Absolutely.
If you tell me other people have more skin
100%.
in the game in the hospital, I tell you you're a liar. Okay, nobody has more skin in the
Absolutely.
game. Nobody has more responsibility, and people that have no skin in the game make decisions that affect outcomes, and that drives me insane. Insane.
So I think the migration to an ambulatory surgical center offers the possibility of reclaiming as physicians that autonomy and that control of our life, right? So I see that as a huge, huge step in that direction. And I really hope that I'm right, because, I'm
I got all my chips in the game.
Yeah.
Pedro, walk me. It's almost like we always say here that we use these interviews as therapy.
They're pure therapy.
It's
Yeah.
pure therapy for both
Yeah.
me and Lucas.
We're saving so much money.
Or free advice. Exactly. We call people we want to interview because we get free advice.
Yeah.
But here's the other predicament. Okay, so I see the writing on the wall. I see the reimbursement for OBL dropping, and I see the ASC reimbursement going up, right? They want us to be pushed in there. I think there's a lot of systematic reasons why that's happening. And I think the fact of the matter, primarily, I think, obviously they want more control over results and they want a better site of service for care. But also because there's other players that could get involved more. With the OBL, you can be incredibly egotistical and keep a lot of people out, and the model can still be, can produce a margin. As you kill that, then we have to migrate into the ASC. As you open the ASC, other entities, for example, a hospital, can come in and have an 8% equity share or a 15% equity share, or a partner like a private equity firm can have an equity position in this. And my experience, and again, I've transitioned out 2 years ago, so that's what Hope's been around, and fully committed 15 months of working in OBL, doing multiple cases a week, yada yada. But as I've started to tip tap on ASC, then all of these entities that I have less control over become part of the algorithm. And so for me, moving out of the hospital and being now in my cocoon of happiness, where I am literally back to being happy. I get out of bed, I'm happy, my staff is happy, the patients are happy. It's just like there's nothing bad about it other than some of the financial burden with the finances and such. But to think that now I have to go back into a pool where it's an ecosystem and there's other people, and then there's this equity distributions, and how do you manage that? What has helped you feel comfortable leaving that place of safety, because it's your show and your show alone, and you know that you trust your instincts and your gut, you know that you can come every day and work your ass off and make what you've built. But now you're relinquishing some of that. And now you're entering into ASC agreements. And now there's multiple people, multiple players, and potentially some entities. What's your thoughts in getting that transition to work?
I mean, honestly, I didn't have a choice, right? Because when you facing a 40% year after year, et cetera, and compounded 40% drop in reimbursement, and your operational costs continue to go up, then you feel the pressure. Number two,
and also the procedures, right? Some procedures just don't work in the OBL.
Yeah, exactly. Then Medicare approves coronary procedures and EP procedures and ASCs and not in OBLs. So, those two factors made it an easy decision to explore the ASC. I think part of and I have to make a little parenthesis, I think part of the reason why we have screwed the OBL space is because, unfortunately, I think that the OBL is a place where some physicians, most of us try to do the right thing, et cetera, but there is a place that there is very little oversight. And some physicians without oversight don't do well. We have a good moral campus, we want to do things correctly, et cetera, but all of us are not like that. And a lot of physicians need oversight. That's an important reason. So, if a hysterectomy pays well, they want to do a hysterectomy on everybody, and instead of following guidelines and following the right thing, and et cetera, et cetera. So I think a few bad apples have ruined the whole thing for us. And when you transition to the ASC, I think is the first key is to choose the physician partners correctly. So the guys that you're gonna, the people that are going to be the physician partners in your ASC are the most important step. Once you have those physician partners aligned and you have to study them, meaning the volumes, you do projections, you do performance, et cetera, and it all adds up. Then the second question is who's going to be your operating partner? So you don't want a hospital to be the operating partner. I am in the position that it's okay to be in partnership with a hospital if they are minority, because you don't want them to have control, but at some point you might want to sell the ASC, etc. And also, if they are in part of the ASC, you can benefit from some purchasing agreements, etc. And easier access to some contracts. There are some benefits to that. And also because some patients are going to get sick and some patients are going to require immediate transfers to the hospital. And you want that process to be like very easy and expeditious. So there are reasons why they might have a role in an ASC partnership. And then the operating partner is the most critical piece of the puzzle, because these are the guys who are going to run the daily operations, and you have to make sure that the philosophy is physician friendly, that you're not gonna, because it can get very very sticky, because obviously the ASC is a completely different game than the OBL. The OBL is an extension of your practice, while the ASC is a completely different separate entity that is completely regulated by different entities.
Are you okay sharing who's operating your ASCs?
Yes. So the one in the north, which is a bigger project, is Surgical Centers of America (SCA), and the one in this in the one in the south, which is cardiovascular specific, it's CCA, Cardiovascular Centers of America. They're both very good. SCA is obviously a huge entity. They own by United Healthcare Group, etc. They own and operate about 240 ASCs in the country now, whereas CCA, they only do cardiovascular.
They're from Florida, right? Originally, that group is from Florida.
They have most of their projects in Florida, but they originally are from St. Louis. So it was started by an interventional cardiologist out of St. Louis a few years ago.
He's still around, right? He's still
around. He doesn't do cases, but he's still around. Exactly. He still goes to the meetings.
Yeah. Like I said, I've been doing diligence on this, so I feel like I've talked to all these people in the last 12 months for different reasons.
And then do you bring partners in because of the required capital to get it off the ground, or because of you need increased volumes? Can two providers have enough volume to keep it afloat?
Yeah, it's all volume driven. So, I think it'll be a significant risk to do it as one provider because, the key man risk, when you're gonna get financing, that's kind of a red flag because obviously if something happens to you, the business doesn't work. So so from a risk mitigation perspective, it's good to have partners, but it's all volume driven. So the important thing is once you have the volume, the financing is very easy. You can get 90% financing. You can even there are depending on the economic climate of the year, etc. Yeah, you might not even need to do personal guarantees. It just all depends on the climate and the region and the which sectors the financial industry is banking on or investing in, etc. Healthcare tends to be very good because physicians in general have a default rate that is less than 1%. So in general, they like healthcare. And ASC is obviously an industry that has a lot of growth over the next projected over the next 10 years. So if you have the right volumes, if you have the right partners, financing is not a challenge.
All right,
That's
Pedro,
true.
this has been amazing. I'm thinking that I want you back on the podcast again. You're like
Anytime, you
thinking.
guys are great.
I'm thinking, no, it's a
Yeah.
given, man.
It seems like you're a fountain of knowledge for business. So thank you so much for coming. Loved it. Very pleasant surprise to have you. And whenever we're in Miami, I'm gonna give you a call. We'll go out for a little cafecito.
Absolutely, I'll hold you to that, of course. Absolutely.
That's great, man. No, I'd also appreciate it. And I may give you a call at some point during the week and just connect with you at a personal level.
Yeah, absolutely. I'd love to stay in touch with you guys. Absolutely, definitely.
That's awesome, man. Thank you very much. Take care, and we'll be in touch. Pura vida.
All right, bye guys.
Vamos.
Take care. Pura vida.
Ciao.